afternoon, everyone. I'm Janet Hughes. I'm a reporter for Gloucestershire Live. I'm here today as part of a collaboration with the NHS in Gloucestershire, and we're looking and exploring at some of their visions for the future. Now, I don't know if you know, but they've had Fit for the Future 1, which has had a look at a lot of the services at the hospitals and how they'll be distributed over the 2 sites. And now we're looking at Fit for the Future 2, which is looking at 6 specialisms. We've already had 3 this week, and today we're going to be talking about a really important one, which is stroke services. And we've got Dr. Kate Hellier, who's the clinical lead on stroke services, and we've got Simon Lansley, who is head of transformation at the Hospital Trust, and they're going to explain to you a little bit about what their vision is, their ideas, and how you can get involved in this conversation, because they want to hear what you think of their ideas and any other suggestions you have. And at the end of this, we'll have a chat with them, and at the end of this, we'll have a public Q&A session. So if you've got any questions, send them in, and we can ask Dr. Kate Hellier and Simon Lansley about this. So first of all, we'll go to Mr. Lansley. Simon, can you tell us a bit about what Fit for the Future is and recap to our viewers exactly what it is?
Yeah, sure. So this is a continuation of a conversation we started back in 2020. So as you say, Fit for the Future phase 1. And this is the next phase. So our clinical strategy remains the same. So the same objective really to focus more on emergency care at Gloucestershire Royal Hospital and more at planned care at Cheltenham General. I think it's important to say it's not a purist strategy. So we're not saying all emergency care and all at GRH and all planned care at Cheltenham General. And you see that through our commitment to Cheltenham A&E. So Cheltenham A&E remains exactly the same as it was. So a consultant-led unit during the day and a nurse-led unit overnight. And in fact, those changes have been in place since 2013. And by centres of excellence, we're not saying that all 30 of our specialties are intending to be centres of excellence in their own right. But our clinical teams tell us that where you co-locate certain services together, that can improve the stabilisation, triage, diagnosis and treatment of patients. So those teams are able to work together, access the same equipment and use the same resources. And then over at Cheltenham General, again, services that are able to plan their care in advance. And you see that through to treatments that patients are booked into for operations or diagnostics, where you can put those together. Those services, again, have more reliable access. So it means we're not cancelling patients on the day because we've got more emergency activity coming in on site. So that's what we wanted to do. It's we're in listening mode, Janet. So again, it's we're sharing some ideas and we're really interested in the feedback.
And it is really important, this feedback, public engagement. People can contribute their ideas.
Yeah, absolutely. Yeah, so in addition to these sessions that we've been running this week, 2 more run into next week. I think we've got diabetes and cardiology to go. The information bus has been all over the county. So it was in Cheltenham High Street yesterday. It's over in Lydney and Gloucester next week. And then we've got some engagement workshops running in the beginning of July. And people, again, there's a website running at the bottom of the screen, and people are encouraged to go onto that and register, and they're welcome to come along to attend any of those sessions.
Okay, thank you. And this conversation that you're having, this public engagement, is going to carry on. It started on May the 17th, and it's going to carry on till June the 29th. But I'd like to come into Dr. Kate Hellier now, who's clinical lead for stroke, because it does mean a few changes to the stroke service as we know it. Can you explain what your vision is and why?
Yes, thank you. There's, I suppose the first thing is just to understand what a stroke service needs. We have changed what's happened in stroke in all the years since I've been qualified, in the way that now we have what we call our hyperacute stroke service, which is the fact that with strokes, if you get to hospital quickly enough, and if you have a blocked artery, which is the cause of strokes in more than 80% of the strokes, then there's the potential that we can either give a drug, a clot-busting drug, to clear the stroke, or actually get somebody to go in with specialised skills and equipment to actually pull the clot out. And the only way that we can do this is if we're co-located with all the teams that are assessing the patients, as well as the imaging machines, the CT scanners, and getting the patients rapidly assessed by the nurses, doctors, as part of the whole service. The next part of the pathway is what's called our acute stroke unit, which is once you've done that very first emergency treatment and management of the stroke, you'll then work through as to whether you need to stay in for anything more than a couple of days. You then go on to the acute stroke unit, where we then work through any recovery rehabilitation needs that you need after your stroke. And then the final bit of the pathway is our rehabilitation unit, which at the moment for the county is hosted down in the Vale Hospital in Dursley. The vision for us with Fit for the Future is to have the hyperacute stroke and the acute stroke unit on the same site, with a view that that gives us the opportunity of having everything together, have the teams absolutely ready to go to answer those calls as the patients arrive. And what we've also managed to do as part of this change is that in the past, patients would either, an ambulance would just do a phone call through to A&E saying a patient's on their way, and then they would contact the stroke team, or else a patient would appear themselves at A&E. Now we've set up a system where we actually speak to the paramedic crews directly. We can have conversations with the paramedics. We can also have conversations with the GPs. And sometimes what I've done is I've even got on the phone, I've asked the paramedics to hand me the phone to the patient so I can have a really good conversation with them to decide whether we really need to bring them in as an emergency. And if so, we then direct them to the right place, which currently for us for stroke is in Cheltenham. And we moved across as a temporary move this winter. And at the moment that's going so well that we're looking towards this being our long-term vision, that we actually co-locate all those services together.
And before COVID, how were they arranged?
Before COVID, if we can go back 10 years ago, where we had two separate stroke services between Gloucester and Cheltenham, and we actually brought the services across to the Gloucester site. And some of you may remember that have been in the county long enough. Before COVID, we had issues with that. The Gloucester site, as everyone will know, is incredibly busy. We often struggle to get patients onto the right ward just due to the bed pressures and the constant issues based in Gloucester Royal. With COVID, we knew early into COVID that we needed to make space in Gloucester for all the COVID patients coming in. And at that point, we opted to move the acute stroke unit back across to Cheltenham, in fact, into Woodmancote ward, which is the ward which was purpose-built for stroke patients when Delancey closed all those years ago. And it's a great environment for stroke patients, a great environment for rehabilitation and recovery. And when we reached a bit of a crisis this winter and realised things needed to improve, needed to change, we realised that bringing the patients back out of Woodmancote back into the Tower Block in Gloucester Royal wasn't going to be best for them. For all sorts of reasons, we then chose to move the hyperacute unit across to Cheltenham, in conversation with lots of national leaders around the country in stroke, who advised us, and it's already reaping rewards of having us all on that site.
I was going to say, what kind of rewards, what kind of benefits does that bring?
The benefits at the moment are largely related to the fact that we are completely focused on those stroke patients getting the right care, the right place, the right time. And because we are a very well circumscribed team and a very well circumscribed group of patients, the ability that we've got by using these direct calls through to us, the ability that we have to direct the patient straight into the CT scanner, mean that the patients are getting the fastest possible access to life-saving, life-changing medication and treatments. When we were in Gloucester, we just never managed to get that degree of circumscribing the stroke patients in a way that gave them a really clear, protected pathway. And it's working so much better in this environment over in Cheltenham, where we can really focus in and get it right day and night, 24/7 for the patients, for the county.
And you have enough imaging and CT scans and everything at Cheltenham to do that?
Yeah, so we were very lucky, very fortunate as part of COVID monies that the government invested in new scanners. And in fact, we put in 3 brand new CT scanners into Cheltenham General last year, and we're using those, and the stroke patients are getting the benefits of those as we speak. And, you know, the scanners over in Cheltenham are as high tech as they could possibly be at the moment for our patients. So it's brilliant.
And you say Woodmancote ward is suited for stroke patients. In what way?
It's very spacious. A lot of our patients the patients that need to stay in after a stroke often have significant needs, often need seating, specialist chairs to sit them out in, hoists, wheelchairs, etc. They need space and around the beds, and we have that in Woodmancote. We have the environment where these patients, who some of them are in hospital for many weeks, if not several months, the idea that they can be in a space which is purpose built for them, with, as I say, space around the bed, space for therapy. There are some ceiling hoists. There are all sorts of things which make it a really nice setup. As much as if you've got to be in a hospital setting, it's a really, it was really well managed and really well thought out by the team that designed that all those years ago.
And in terms of disadvantages, there must be an impact on some people, that drawbacks.
Yeah, obviously there's the geographical disadvantage for patients on the west side of the county, because they have to go past Gloucester Royal to get through to Cheltenham. But actually that extra movement for us at the moment, we have to have the service in one of the hospitals. We can't have it in both. So the idea that we have it in one, which is working together with everything on the Cheltenham side, works really well. And at the moment, I've had very few, if any, upsets from relatives. All they really want is to be in the right place for their treatment. And bearing in mind that some patients that can receive this special clot busting treatment, which is called thrombectomy, which is where people go in and suck the clot out, that's actually done down in Bristol in Southmead Hospital. So patients inevitably with stroke are going to be moved to the area that can best meet their needs. The important thing is that we've got the team ready and waiting for the patients as soon as they arrive, and we're enabling the patients to get to us as fast as they can for the whole county. There, of course, might be questions about what happens if you turn up in Gloucester with a stroke. Well, part of this, the move involves us making sure we're trying to raise awareness for public health, for the public to know that if they now have a stroke, they should be trying to get themselves, if they're self-presenting, that they should be trying to come across to Cheltenham. However, we have a very clear setup and pathway with the Gloucester Emergency Department, so that if any patients arrive, they can either get passed straight on through and say, look, if an ambulance appears, don't stop, keep going. And if all families turn up, then the triage nurses, the doctors, the emergency department get straight through to us, and we divert the patients as quickly as we can.
And do you have a means of diverting the patients?
Absolutely. So we've got, obviously we have ambulances that we will use as and when they're available. Part of the Fit for the Future plans is to work on making sure that we've got availability of our own in-house transfer teams, with a view that what we're not going to do is disadvantage any patients, either by using public ambulances that otherwise should be needed out in the community. And I believe, I don't know if Simon wants to comment further on that, but that's one of our parts of our planning with regards to Fit for the Future too, is making sure that any cross-county transfers for patients are really optimised as best they can be.
Because that's what I was going to ask. As a clinician, the first thing you hear about stroke is that everything, time matters, speed is of the essence. Do those people who have to go past Gloucester to get to Cheltenham in an ambulance, do they have anything to worry about with that?
They shouldn't do. Again, if it's just a matter of minutes getting them between the two sites, that's the important thing. I think the key bit for us, as to whichever site we ended up on, there will always be patients have to move from one site to the other. So the important thing, while we remain a two-site hospital, which we are, and we've got no plans of getting rid of that option, while we remain a two-site place, it's really important that we make sure that patients can get between the sites as quickly and as effectively as possible. The other
Janet,
part, sorry, I'll let you say, Simon.
Thanks, Kate. I was just going to add there, just to link to your some feedback we had from the first phase of Fit for the Future, Janet. So, so patients and families told us they understood that, in the 2-site hospital, sometimes you have to move between the two, but actually travelling a bit further to access the right care first time was more important. So Kate earlier on explained that when the trusts, the 2 hospitals first came together, we had duplicate services on both sites, which was unsustainable both from a workforce perspective and a kit and equipment perspective. So having it on one site means that when you do arrive, you've got the right kit, the right team to look after you first time and go through the pathway that Kate's described. So it's always a difficult trade-off, but it was interesting to get that feedback in the first phase of Fit for the Future, that patients found that more important.
That basically it's more well defined, and I suppose a lot of it will depend on the ambulance crews and the relationship with the hospital, really, won't it, about where people go. Okay, well, that sounds, you've explained that really well about what it means. I'm just wondering, do you know what kind of numbers people are involved here in terms of how many people have strokes and how big it is in Gloucestershire in terms of a problem?
So we have just under 1,000 strokes a year that come through Gloucester, and that's confirmed strokes. We can see, sometimes we say about every 4 to 1. So we can have 3,000-4,000 strokes or potential strokes coming through. Some of those turn out to be TIAs or mini strokes, and some turn out to be other diagnoses. But of the established strokes or the confirmed strokes, it's about 1,000 a year.
So, okay. And I presume that might be evenly split between, it's spread across the county, isn't it? I'm taking it, yeah.
Absolutely, yeah, from all areas.
Okay, well, that's great. Thanks for your input there, Kate. And Simon, can you tell us a bit more about how people can get involved now?
Yeah, sure. So again, there's further these sessions running next week. We've got diabetes and we've got cardiology to go. I'm hoping people are starting to see there's booklets around the county, certainly around the hospital sites, that people can complete the survey at the back. The key website is running across the bottom of the screen. There's lots of information on there, again, which talks about where the bus is appearing, that you can have more detailed conversations and some of the engagement workshops as well. One thing I forgot to mention, Janet, it's probably really important to say what this phase is not about. So I hope I was really clear around Cheltenham A&E, but it's also not about the service changes that we discussed in phase 1. So 7 of those reconfigurations that we talked about have been agreed, and 5 of them have been implemented. 2 more still to go, which is the centralisation of our acute medical take and the launch of our image-guided interventional surgery service as well. So not about those changes, and also not financially driven. So there may be some areas that we need to invest in to deliver some of the changes that we've talked about, but it's not a cost saving, it's about a quality and safety exercise.
Okay, and what I'll do here, just to be clear, I'll read through the services that this is about. It's about 6, and it's about benign non-cancerous gynecology, diabetes and endocrinology, frailty and care of the elderly, non-interventional cardiology, respiratory and stroke. And they're the 6 areas, the 6 specialisms that this Fit for the Future that we're here to talk about, isn't it?
That's right.
Yeah. So we've already done frailty, respiratory, benign gynecology, and we're doing stroke today, and we've got diabetes and cardiology next week if you want to tune in and find out more. But I think Simon is going to tell us a bit what happens next.
Yeah, so again, as I said, we're in listening mode, so sharing these ideas and through all the various means that we've talked about, listening for feedback. We'll then take that feedback and see if there's some key themes that we need to address and respond to those. There's something called an outcome of engagement report, which sounds very corporate, doesn't it? But that's the way we put everything together and say, these are the messages we've seen, here's how we've incorporated those into the changes, and then we'll come back out and do some more sharing of those themes that we found. And then we're on into discussions. Then depends. We always engage with our local health overview and scrutiny committee, so making sure colleagues are aware of the changes, and through that we'll agree on next steps.
Okay. And in terms of the changes, do you know when they might be coming about? If they're all agreed and people are behind these ideas?
Yeah, so it's typically an 18-month implementation period. As Kate mentioned, some of these changes are in place already, so we implemented them as part of our COVID response. And that's beneficial to us. So as the examples that Kate's given today, we can give real life examples of why it's better for patients and their families. So 4 of the 6 that we've talked about, the changes are there. 2 of them would be, again, based on the feedback we get, would determine how quickly we could implement those.
Okay, and unless anybody else has got anything to say, I don't think we've had any questions from the public yet, but are you happy with everything, Simon and Kate?
Yeah, I think we've covered the key points. Yeah, thank you.
Yeah. Okay then. Well, with that we'll say goodbye, and we'll see you next week for diabetes and cardiology. And thank you for joining us and outlining all the ideas you've got and the vision for the future.
Thank
Okay
you.
then. Thank you. Bye.